Welcome back to our education series on type 2 diabetes. In the first episode, we explored what's really happening in the condition, from macro drivers like diet and sedentary lifestyle to the micro dysfunctions in the pancreas, kidneys, gut, and brain. In the second episode, we focused on lifestyle as the foundation of treatment. Today, in episode 3, we turn to an equally important theme: targets and personalization. When we think about targets in diabetes, the HbA1c is often the first number that comes to mind. NICE guidance suggests aiming for an HbA1c of 48 millimoles per mole or 6.5% if the patient is managed by lifestyle alone or with a drug that does not cause hypoglycemia. If the patient is on sulfonylureas or insulin, the target is a little higher at 53 millimoles per mole or 7%. These targets help to guide treatment intensity, but they are not rigid. They are a starting point that needs to be tailored to the individual sitting in front of us. Take, for example, a 42-year-old man with newly diagnosed type 2 diabetes, a BMI of 31, and no significant comorbidities. He is motivated to make changes and has a long life expectancy. In this case, aiming for tight glycemic control makes sense. Achieving an HbA1c close to 48 can reduce his risk of microvascular complications, protect his cardiovascular health, and potentially even open the door to remission. Now contrast that with an 84-year-old woman with frailty, chronic renal impairment, and a history of recurrent hypoglycemia. In her case, the priority is quality of life, not aggressive glucose control. Chasing an HbA1c of 48 could do more harm than good. Here, relaxing the target, simplifying the regimen, and focusing on avoiding hypos are much more important. This is the essence of personalization. The numbers are only part of the story. We must always weigh them against comorbidity, frailty, polypharmacy, and patient preference. Some patients want the tightest possible control. Others prioritize reducing the burden of tablets and injections. Our role is to explore those priorities and set targets together. We also need to avoid therapeutic inertia. This is the term used when treatment is not intensified or de-intensified when it should be. For example, a 56-year-old woman has an HbA1c of 73 despite being on metformin and gliclazide. If we simply tell her to work harder on lifestyle and review again in 6 months, we risk allowing high glucose to cause ongoing vascular damage. On the other hand, if we keep an 80-year-old patient on a complex regimen of 4 different drugs, all to achieve a number that is no longer clinically meaningful, we risk overtreatment. Both situations reflect inertia, failing to act in line with what the patient needs now. And it is important to remember that glycemic targets are only one part of the equation. For macrovascular protection, blood pressure control and lipid management probably matter more than glucose. For microvascular outcomes like retinopathy or nephropathy, glucose still plays a big role, but even then, blood pressure is equally critical. So when we review a patient's targets, we should think of HbA1c alongside blood pressure, cholesterol, kidney function, and lifestyle behaviors. Let's bring this back to the consultation room. When you see your next patient with type 2 diabetes, don't start by thinking of HbA1c in isolation. Start by asking, what matters most to this person? What are their risks, their priorities, their burdens, and their life expectancy? Then set targets that are safe, realistic, and meaningful. So, to summarize this episode, aim for HbA1c of 48 millimoles per mole if on lifestyle or non-hypo drugs, and 53 if on sulfonylureas or insulin. Personalize those targets based on frailty, comorbidities, and patient choice. Avoid therapeutic inertia, act when you need to intensify, and act when you need to simplify. And always remember that diabetes management is about more than glucose, blood pressure, and cholesterol matter just as much. In our next episode, we'll move into pharmacology. We'll look at first-line drug therapy, starting with metformin and the growing role of gliflozins, and discuss how to bring the latest guidance into everyday general practice. That's it for today's quick medical review. If you found this helpful, share it with a colleague and subscribe for more clinical gems every week. Until next time, stay sharp, keep learning.